Welcome to live Q&A with the experts of Rome Foundation. My name is Tanya Murphy, Rome Foundation's Executive Director. Today's session is titled Updates in Gastroparesis. I am your host, Tanya Murphy, and I am excited to be with you here today. I'd like to introduce my co-host, Dr. Douglas Drossman. He is the CEO and President Emeritus of Rome Foundation and Drossman Center of Education and the practice of biopsychosocial care, and also Professor Emeritus of Medicine and Psychiatry at the University of North Carolina, Chapel Hill. Dr. Drossman is also the founder of the Rome Foundation and is an internationally recognized scientist clinician and an educator in DGBI and communication skills training. He is the CEO. That was already repeated. He is the founder of the Rome Foundation and is an internationally recognized scientist, clinician, and educator in DGBI. Today, Dr. Drossman is joined by the newly minted Rome Foundation board member, Madhu Grover. He is the associate professor in the Department of Medicine and Department of Psychology and Biomedical Engineering at Mayo Clinic in Rochester, Minnesota. He studies mechanisms involved in the pathophysiology of irritable bowel syndrome, which of course is IBS, with a specific focus on the role of intestinal mucosal barrier function and microbiome. Additionally, his laboratory investigates mechanisms of gastroparesis in humans and animal models, and he is a steering committee member of the NIH Gastroparesis Clinical Research Consortium. He also chairs the Rome Foundation Biomarker Core, as well as the director of the GI Motility Group at Mayo Clinic. I now turn things over to Dr. Drossman.
Hey, thanks, Tanya. And hi again, Madhu. It's great to see you. Just for those of you out there, although Madhu has been on the board about a year or so, we actually go back over 20 years when you were a resident in Michigan State and you came to spend a few months. And I found it remarkable that in 3 months' time, working with me and Bill Whitehead at the time, you published about 6 or 7 papers. And I think that gave me the evidence that you had a real future career in this area, as you have done with your research at this time. So welcome. It's great to see your career evolve and to continue to work with you.
Thanks, Doug. Thanks for your remarks, and thanks, Tanya, for that kind introduction as well. Happy to be here. Looking forward to the conversation.
Well, we have an interesting topic. It's update on gastroparesis, and I think most of us in the field in neurogastroenterology and motility have been struck by the fact that there's maybe a little bit of confusion when motility people talk about gastroparesis and the DGBI experts talk about dyspepsia, because the phenotype can be very similar. So let me start with, what is the difference? Why do you differentiate between gastroparesis and dyspepsia? Maybe define what those syndromes are.
Yeah, excellent point, Doug, and the question. Thanks for the question. You're absolutely right. I mean, conventionally, we have seen these disorders in different lights, where we have articulated functional dyspepsia or non-ulcer dyspepsia as more in that under that umbrella of disorders of gut-brain interaction, and we have treated gastroparesis as its own entity, as a neurogastrointestinal disorder. And what we have learned looking at patients over the years, and this is no surprise to us and to you, seeing these patients, that the symptoms of gastroparesis and functional dyspepsia are very similar and often overlap to a remarkable degree. When you see a patient in the clinic, often it's impossible to tell based on the symptoms alone. But there are some differences between these two disorders. Conventionally, gastroparesis is defined with symptoms suggestive of gastroparesis, along with an objective evidence of delayed gastric emptying, which is ordinarily defined by challenging an individual with a solid meal and assessing using scintigraphy, how their stomach performs at 2 and 4 hours, and there are objective criteria. That said, what we are learning more recently, and this is some of the work that NIH Consortium has done, when you follow patients with dyspepsia or gastroparesis over a period of, let's say, about a year, many patients can flip their categories. In other words, if they started with dyspepsia, they can now develop delayed gastric emptying, or at least show evidence of delayed gastric emptying that they didn't show earlier. And on the other side of spectrum, they were delayed to begin with, but about a year later, in a subset of those patients, the gastric emptying has now normalized, even though they continue to have symptoms, which are still suggestive of the same condition. So again, I think we are entering an era where not only we know that symptoms are overlapping, we are also learning that these conditions can evolve towards each other over time. There are some, consensus statements, particularly from Europe, which have suggested that if you have symptoms of nausea and vomiting, you are more likely to fall in that gastroparesis umbrella versus if you have symptoms such as epigastric pain, postprandial distress, bloating, and those symptoms are often harder to, discriminate dyspepsia from gastroparesis. So again, we do look, when we take care of patients, we do look at that nausea, vomiting phenotype. And if that's making a predominant picture, we tend to think about gastroparesis.
I think that's a point to emphasize, that when nausea and vomiting is present, they are more likely to have the delayed gastric emptying and be diagnosed as gastroparesis.
Yes.
If I could just drill down on that a bit, I think the question often is, when we see patients and we call them dyspepsia, with or without the nausea and vomiting, and they happen to have had a gastric emptying study, and let's say it's 20% abnormal. When do you decide that you're going to treat with, say, a prokinetic as opposed to one of the other agents, like a receptor agent like buspirone or anything to receptive relaxation?
Yeah, that's, again, when I look at gastric emptying results, obviously one has to be careful while interpreting the results, right? A lot of times the gastric emptying studies are done for insufficient amount of time, when they do the study for 150 minutes, 2 hours, and extrapolate the curve to see how the stomach might do over time. Other times they are not done with a solid meal. So again, the technical aspects of gastric emptying study are at least important to us in the clinical practice. And to be very honest, we are very conscientious of not calling mild delay as true gastroparesis, because studies have now shown that if you take a healthy individual and do a gastric emptying study on them now, and a few days or a few weeks later, there can be up to 15% variability in the values. So at least in my practice, I look at look at results that are outside of that variability. So I want to see 25-30% retention at 4 hours before I feel comfortable going down that path of treating them more as gastroparetic versus dyspepsia. Again, this brings the bigger question, because often the treatments are overlapping as well, as particularly considering the lack of treatment options for gastroparesis.
Thanks. The next question, I think we're in a situation now with the GLP and GIP agents, receptor agents like semaglutide and terzepatide, that they do cause nausea and vomiting. How does that relate to gastroparesis?
Yeah, and this is a question which is very timely, as you can imagine, because a lot of patients are going, on these drugs for, mostly for obesity, but also for an expanding number of indications, sleep apnea, substance abuse, and so on and so forth. So we are seeing this progressively in our clinics. There have been some, data out there suggesting that 1 in 8 U.S. adults have at least been on one of these drugs at one point over the last several months. So, particularly a lot more is, happening. A lot more agents are coming to the market as well. So, partly GLP-1 agonism, partly this delay in gastric emptying phenomenon is built within the mechanism of action of GLP-1 agonism. So, and these are studies dating back 2 decades where in healthy volunteers, as well as in patients with, diabetes and so on and so forth, people gave intravenous GLP-1, and they found that they do have effects on the stomach, and they do slow the stomach acutely. But I don't think we understand the full picture when we look at the patients here. At least in our experience, and we presented early findings from this study at this last DDW, that about a third of patients who had bothersome symptoms after GLP-1 agonists had delayed gastric emptying. So it's not everybody who is having GI symptoms that were bothersome enough for them to go to a doctor would have necessarily gastroparesis. We do know, for example, constipation can happen with these drugs as well. But perhaps there are other mechanisms which are at play as well. I would say mechanistically, much more needs to be done, particularly in the setting of real patients who are going on these drugs, to understand what are the different mechanisms in different patients that result in their GI symptoms becoming bothersome enough that they either want to stop the drug or decrease the dose. Obviously, many patients would feel mildly nauseous, and they would see that as a therapeutic effect, which would be attractive to them to not consume as much as they did before. So I think this is an emerging field, and we and others are very interested in understanding the mechanisms at play.
Thank you for that. We often think about dyspepsia as being symptom-based based on their own criteria, and gastroparesis as the motility study. But what's coming up? What's new in diagnostics for these disorders?
Yeah, so conventionally, as I was saying earlier, gastric emptying scintigraphy has been the gold standard for dyspepsia. At selected centers, you can do specialized imaging to understand gastric accommodation, for example, which is a problem in many of our functional dyspepsia patients. Again, not widely available. But there has been some progress, I would say. Electrogastrography has been in existence for many years, but I think lately that has seen some resurgence with the whole body and sort of that high resolution gastric mapping, where multiple sensors are placed on somebody's abdominal wall, and they can give a much more sophisticated understanding of their myoelectrical activity in the stomach. So I think studies, particularly over the last 12 to 18 months, are suggesting that these modalities can allow us to differentiate patients that are driven by a gastric mechanism or a gastric neuropathic or a myopathic mechanism versus something going on centrally or outside of stomach, in which case they might fit more in that dyspepsia paradigm. Again, a lot of work, evolving field. There are other investigations, for example, in gastroparesis, like things like endoflip and high-resolution gastroduodenal manometry, which is, in my opinion, seeing a resurgence of use because there are now treatments, particularly things like pyloromyotomy, which can be done endoscopically for the gastroparetic patients. So I think we are moving, thankfully, we are sort of moving away from doing a diagnostic just for academic purposes. And in fact, and I hope this continues to evolve in this direction, where some of these, advancements in diagnostics can help us triage patients who might be better suited for a therapy like GPOM. So I think there has been progress, and there's a lot of talk and planning about improvising on gastric emptying as well. Can we do dynamic imaging, which can help us understand stomach at a much higher resolution? Can we look at MRI imaging to look at the stomach and its motility? So I won't be surprised 2 to 5 years from now, we would see much more advancement for both of these conditions in terms of diagnostics.
What about dyspepsia? I believe at your institution, you've looked at receptive relaxation of the stomach. Does that have some clinical value to decide on treatment if you can assess that?
Yeah, so we do spec-based imaging where we would have a technetium label and have the individual consume a caloric, fluid over time. And what we're trying to really assess is the delta of their stomach volume from baseline. So in other words, how much can their stomach expand from a fasting state? And based on doing this study on healthy volunteers, we have developed normative data, which we use to then define patients who have impaired accommodation or impaired, receptive relaxation. And if I see that, I am much more likely to try an agent like buspirone, for example, which has been shown to have some properties. And you would find this interesting, Doug. There was a study that Mike Camilleri and colleagues published a couple of years ago, or actually more than a couple of years ago, when they took diabetic patients who came to our clinics for upper GI symptoms. And if you look at patients, and in the study, they took patients who had both gastric emptying and accommodation study done. It's really a smatter. About a fourth of patients have an abnormality in both accommodation and emptying, about a fourth emptying alone, a fourth accommodation alone, and a fourth neither. So it is plausible that if these tests become more widely available, we are able to put patients in categories that can help treat them.
Do you know the degree to which the accommodation findings relate to the symptoms of early satiety and fullness?
Yeah, not many good correlation studies available, because I think doing the proper accommodation is still restricted to highly selective centers. So unlike gastric emptying, where a lot more correlation type work has been done with symptoms, which often find limited correlation, I don't think we understand the whole association between early satiety, postprandial fullness, and accommodative changes very well.
Yeah, it would be nice at some point to have a good biomarker to diagnose and treat and see the response physiologically. So how do you treat gastroparesis? As there is metoclopramide, which is approved. What else? Domperidone is not available in the US, but a lot of people get it from Canada. Tell us more about how you treat gastroparesis.
Yeah, so and this is where the sore spot is, right, for people who take care of patients with gastroparesis and dyspepsia. And this is an area where it's very personal to me at times when we think about the treatment landscape and we realize that the last approved drug was over several decades ago. And we are still in the weeds, honestly, trying to extrapolate and use antiemetics, prokinetics that are really off-label for this condition. And often do not result in remarkable treatment success, particularly when that gastric emptying is severely delayed, when the patients are struggling maintaining their hydration, maintaining their nutrition. So I think the pharmacological armamentarium continues to remain extremely limited. There have been drugs, things like prucalopride, approved for constipation. There is some data and evidence to suggest it may help with gastric emptying. There have been some studies done through NIH Gastroparesis Consortium, and given agonists like aprepitant or tradipitant may show some efficacy, particularly in patients with nausea and vomiting. But the mechanism is likely not due to their effects on gastric emptying. It's probably more sensory mediated mechanism. So we have had, and I'll be honest to you and being candid, we have had setbacks as well in drug trials for gastroparesis, because I think we struggle a bit with endpoints and how to best design the right clinical trial. And there's a lot of work going on in that direction as well. As I look at the future, and again, I feel more passionate about this than maybe others, because through our efforts in consortium and our involvement particularly, we have done a lot of work looking at the gastric tissue from patients with both diabetic and idiopathic gastroparesis. And we have learned that I'll be, in sort of contrast to the prior view that there is a neuropathy and enteric nerves are affected, it's in fact loss of ICCs, which are pacemaker cells in the stomach. And what we're also learning, interestingly, that there is an evidence of immune dysregulation in these stomachs. So that's kind of a critical finding, which if you think about it, 10 years ago or 15 years ago, if you asked that gastroparesis could be immune mediated, people won't have that opinion or any data to say or suggest that. So I think as we think about the next phase of gastroparesis treatment, we want to think like IBD. How can we disease modify this condition? How can we get to a state where we can attack that immune dysregulation so that the downstream symptoms get better rather than always staying with that symptomatic side of our efforts? So hopefully through smaller trials and proof of concept studies over the next few years we have in the Gastroparesis Consortium, in this cycle, we will be able to make some progress in that direction. So that gets me excited for the field, because I think it's driven by the findings that we and others have generated. And I think there is a plethora of immunomodulatory therapies out there that can be possibly used.
That's really interesting. I'm thinking about how we look at even conditions like IBS and their association with POTS and mast cell activation and small fiber neuropathy. And we're starting to expand the symptom-based model to look for physiologic markers. Well, thank you very much. This was very informative. Any last words? And you've really given us our last words, but please take another minute if you want.
No, sure. No, thanks for the dialogue. And I appreciate the opportunity to have a conversation on this topic. I think we are developing a progressively increasing appreciation of how bothersome these symptoms can be for the patients. And particularly your question about GLP-1 agonists, it's making us realize all over again how troubled patients can get from these symptoms, which can be due to delayed gastric emptying or an associated mechanism. So I think there is a pressure, which is the right pressure on us as academicians and researchers to think hard and carefully about what have we learned over the last 5 to 10 years in terms of pathophysiology. What are the new tools that are available to us? And there are many over the years. And how can we use those tools and that understanding of pathophysiology to make a dent in this condition? Because I think we are going to see more, not less, patients with gastroparesis down the line.
And can I ask a question, Dr. Grover? If a person has gastroparesis currently, going back to your second question that Dr. Drossman asked, is it something that they can look into to take a GLP-1, or do you typically not advise that if they already have gastroparesis?
Yeah, that's a great question, and it's not infrequently that we are getting asked that question. So if you think about it, right, the fact that we know somebody has gastroparesis almost tells us that they were having symptoms, bothersome symptoms that prompted us to do that gastric emptying study. So I like to tell them very candidly that there is a probability that things can get worse. And I don't like for them to go on GLP-1 agonists if their gastroparesis is not under good control. But I do offer my willingness and help to work with them and probably get them to a condition or a situation where they are able to manage their symptoms very well, and they are not decompensating with their disease before they go on a GLP-1 agonist. But much more frequently than not, at least as of now, the caution is very high for these patients to go on GLP-1 agonists.
Sure.
Yeah, that's an important question because, as you pointed out, 1 in 8 have been on these already. Maybe it would unmask it in some people.
Yes.
Tanya, any final words? Thank you again, Madhu.
No, wonderful, wonderful discussion and questions. I think this can really assist a lot of patients with a lot of questions that they have that they just haven't been able to see their physician about, or haven't been able to get answers. So thank you so much, both of you, for today.
Thanks once again.
Bye, everybody.
Bye-bye.